Well, hello there. I'm your co-host for today, Dr. Kate Kresge, and we've got a really exciting episode for you today. It's with my friends, Dr. Chris Magryta and Dr. Erik Lundquist. We're going to explore the transformative power of what seems like basic blood labs testing in your clinical practice if you know how to do it right. Now, Dr. Chris is a pediatrician at Salisbury Pediatrics, and Dr. Erik is an internal medicine family doc at Temecula Center for Integrative Medicine. So they treat both kids and adults. And turns out there's a ton you can do with what seems like basic labs for kids and adults to gain really important early insights into things like cardiovascular health, metabolic health, immune system health, thyroid health. We're going to cover it all today, but we cover it in even more depth in the upcoming bootcamp that we have with these two amazing physicians. It launches in January 2025, and you want to be on the list, because you're going to learn optimal lab values for dozens of biomarkers. You're going to learn how to create a custom cardiac screening panel that looks for more than just your standard lipids. And most importantly, you're going to understand why. So this really helps you stay on the leading edge of what's optimal in a time when patients are asking more for this than ever. And these docs are also going to equip you to understand how to do this in an insurance model. So what ICD-10 codes are you going to use to get these labs covered for your patients and more? You're going to love this conversation today, and you'll love the course even more if after it, like me, you want to spend more time with these docs, ask them your questions in 6 weeks, 6 hours of live Q&A, and a ton of recorded lectures that our students routinely rave about. So let's dive in. Dr. Chris Magryta and Dr. Erik Lundquist, welcome to the Root Cause Medicine podcast.
Thank you.
It's a pleasure to be here. Thank you so much for having me.
Thanks for being here. This is going to be a fun conversation. And I'm personally pumped because we have a couple more fun conversations coming up in a few weeks when you guys are teaching a course about functional medicine interpretation of blood labs, which I think is going to change the game for so many providers who are doing primary care, pediatric care. We need this course more than ever right now. So before we dive into sort of the surprising hidden pearls in a lot of the standard labs that most doctors are missing, I want to ask you guys, why now? Why was this topic important for you to cover now?
I think fundamentally for me, the reason this is so important now is, look at how sick our kids are getting, right? And so in 25 years of being in private practice, you see this continual pattern of a declination in health span or the quality of life during the time these children are alive, more diseases. In the past 3 months, we've had 6 cancers. And so we're just seeing this absolute change in disease onset. And so for me, the ability to go upstream and find out why these diseases may be happening in the first place through history, through physical exam, but importantly through lab analysis, maybe we can stop some of these trends from occurring. And so for me, I think that's the quality reason why this is a timely discussion.
Yeah, and so I'm going to share a quick story in a second, but I think to specifically answer your question, why now? Because RUPA is giving us a voice to share. I think, in reality, it should have been done 20, 30, 40 years ago, right? And so here's my story. So I remember about 15, maybe 18 years ago, I was sitting in a room with a patient. And I've always been kind of a big lifestyle advocate, always trying to get my patients to improve their diets, improve their lifestyle, get more exercise, get better sleep. But in the conventional medicine world I was trained in, and I had 10 to 15 minutes with that patient, and there's not a whole lot I can communicate in that short amount of time. Well, I had a patient coming in. They were on at least 7 different medications. They were maxed out on like 4 different diabetes medications, and we were going over their labs, and their insulin was 8.5%. And I had nothing to offer them. They said they were already making their lifestyle changes, which again, we have so much more data now that allows us to give feedback right away. But I didn't have really anything to offer them but insulin. Now, as a provider who is integrative minded, functionally medicine minded, that's awful. That's like telling your kids there's no presents for Christmas, right? I mean, it's just an awful, awful thing. And it broke my heart. And I realized, okay, I've got to change the way that I can't stay in this system anymore. I was done. And so I jumped out. But having the labs, understanding how to interpret these labs early on, right? I didn't need to wait until this patient had diabetes and then had an A1C of 8.5%. I could have picked up on their insulin resistance and their blood sugar dysmetabolism early on, and we could have done things then that could have changed the whole world for them. And now you combine these blood biomarkers with some of the wearables and the data we're able to collect, the combination of those two things. So I'm going to finish it with a really awesome story from a patient I literally saw yesterday. And we've been going over labs, and he's doing his best, but patients always say they're eating well, but you can look at their labs and know that they're still not quite. And he was doing okay. We've been struggling to get his insulin down below, his A1C down below 7.6%. And he got a Freestyle Libre. He started having continuous glucose monitoring, and we were able, now that he had that feedback, his A1C was 6% after 3 months. 3 months. His lipid panel significantly improved. So understanding the biomarkers, understanding this feedback system, the combination of that, these are tools we can use to help educate our patient. They get the feedback. They're willing to make the changes. And we're at an exciting time now. I mean, it is super fun to be a functional medicine doctor.
Oh, love that.
Yep, 100%.
Okay. I mean, you guys, so anybody who's listening, who's a clinician, you guys can go to ruperuniversity.com and look at the boot camps and sign up for this amazing boot camp that's coming out on blood labs interpretation from Dr. Erik and Dr. Chris. And I just want to give folks an idea of what you cover, because I think there's two really special things you're doing in this boot camp. The one is you're taking standard labs that docs are used to ordering, but you're teaching people how to go deeper with the results they get back and how to use a functional lens and an optimal results lens and look at ratios and insights they might not have known they could get from what they're already ordering. But then there's a few extra things that you can add, for example, to a lipid panel, 1 or 2 extra biomarkers that actually make that lipid panel way more valuable for catching things early, for doing preventive care, for doing care for longevity. And so I'm super excited, and you guys are going to talk about a few categories: heart health, thyroid health, immune regulation, metabolic health, blood or antibodies health. We're going to look at nutrients in the blood. And so I want to start with looking at a lipid panel and heart health. And so what's the approach that you guys are going to teach doctors to take when it comes to the lipid panel that's going to give them some extra insight than they're already getting?
I think first, before we talk about the actual biomarkers, let's talk about why a lab in a functional medicine approach really looks different than the lab in a conventional medicine approach. Because I think, as Dr. Erik, talked about, he's, doing this stuff now in a very different way outside of the system. I'm actually still in the system in the general pediatric world, seeing a lot of Medicaid kids, and this can be done in both worlds. And that's the beauty of this ability to teach, because it's not siloed to one side or the other. But I think fundamentally the biggest piece is it's not binary. I think we really need to look at this. And so when we look at lipids, we're going to talk about why it's not a binary reality, that the biomarker, whichever one we're looking at, sits at X number. If you are above X number, you're now in trouble. If you're below X number, you're totally fine. And there's almost nowhere in the world where that's really true. Think about toxins, chemicals, the lead poisoning level, if it's above a 3, it was considered, okay, you're in trouble. But if it's less than 3, you're fine. Well, it turns out that's not true at all, because 2, 1 are still causing disease damage, just not to the point that you get there really quickly. So I think we need to sort of look at it from that perspective right out of the gate. And I think anthropologically, this also makes sense, because when you go back through a continuum of history, humans have been living in a world where the exposure to the outside world has relatively been the same up until the last 50 years. And these last 50 years of change of our, to Dr. Erik's point, lifestyle, we've now changed how the body sees these inputs in a way that now they're causing disease. And I want to hammer this piece home. When we do these lab tests and we look at these biomarkers, it's generally not a dysregulation of the human host. The human host, the genes, how they're functioning are actually the way they're supposed to. It's the mismatch, sort of the polar bear in the desert phenomenon, that we're actually seeing. And so when we think about lipids, to me, the most important part of looking at lipids in the old school way, when I was at Emory at a UVA, we were taught that, LDL cholesterol is the bad cholesterol and HDL cholesterol is a good cholesterol. Well, now usher in 25 years of looking at the drugs that were made and things that were really put to lower these levels. We're finding out that, lowering LDL in and of itself does help, but is it the answer? No, because lots of people have normal LDLs and still end up suffering ASCVD or coronary vascular disease. And then HDL, a bunch of drugs came out looking at HDL, the molecule, and raising the level, thinking, oh, it's the good cholesterol. You raise the level, we should mitigate disease. And it turns out that's not entirely true. And so what functional medicine has done so well is now look at the continuum of what these labs mean, but also now look at the function of them. And I think this is where what this course can teach is now we can start to say, okay, well, the lipid level, the LDL level is 130 or 200, and that's high. But what else is going on with it that's saying it's dysfunctional, right? And so to your point, do you have an associated Lp(a)? Do you have an associated elevated a high sensitivity CRP? Is your myeloperoxidase high? So there's a bunch of other tests that can go along with an LDL or an HDL, the standard lipid panel, and then give you a little bit more answers, right? And we're starting to see creep into the conventional literature. There's been now about a decade where folks are talking about particle number, and particle number is super important. But again, what's the function? How well is it working? And the reason that a lot of these things are becoming dysregulated is because of inflammation. And I want to hammer one little key point here, and then I'm going to turn it over to Dr. Erik to spin on this a little bit. But if we look at, somebody who has an elevated LDL, and oh, by the way, they happen to live in the rainforest of South America. There's a group there called the Tsimane Indians. And when they looked at them, they had almost no ASCVD. Less than 15% of the population had any signs of ASCVD with a CAC score that was mildly elevated in the 1 to 100 range, which was even really super high, but they had really almost no disease. But oh, by the way, they had an elevated CRP level, which meant they had inflammation. And they had some LDL and HDL levels that were a little bit higher. And so when we look at these things, taking them on balance, that it's just the number as a binary reality of disease risk or not disease risk, it doesn't work that way. And functional medicine has become an incredibly powerful tool in the toolbox of the provider to say, what else is going on that gives me an analysis of actual function in the body, what's happening, and what do we care about? And then during the course, we'll get into the nuances of what each number means and how much that number is relative to the other biomarkers that give us a risk factor for disease onset. And again, in kids, when we think about this, I'm the pediatrician in the room, ASCVD starts at birth, and that's pretty clear now. And so the earlier we intervene, the more important it's going to get.
Love it. Dr. Erik, give us more.
Dr. Chris, that was very well stated. And I still have the polar bear stuck in the desert in my mind right now. But I think that it's a very, very valid point. And there's so much that we can obtain information-wise in terms of diet and genetic expression, lifestyle that impacts how that lipid profile is reflective of that individual and what they're going through. One of the exciting areas of my approach to my patients is looking at the influence of stress on their lives. Adrenal gland function is one of my favorite things to do. And we know the impact that stress has on the cardiovascular system and increasing risk for cardiovascular disease. But what is often forgotten, and I did not know this until it actually was put before me, is that all of the stress hormones come from cholesterol. In other words, a natural biological response to stress is to increase your cholesterol because you need to make more hormones. And we forget about it. So what do? We give a cholesterol-lowering agent, which then suppresses the body's ability to respond to stress. That's not good. And it may help explain why less than 50% of the people who get heart attacks have abnormal cholesterols. More than 50% of people who have heart attacks, a cardiovascular event, have what is considered a normal cholesterol, an LDL of less than 130 or a total cholesterol of less than 200. And the Jupiter study showed us that. Now, when you combine inflammation, we see a little more correlation with a high sensitive CRP. But it's really important to think about what is going on in this individual's circumstances. What's the stress impact? What's the diet impact? What's the genetic expression? Do they have MTHFR? Are they producing more homocysteine? Are they not detoxifying well? Is that contributing to their overall situation, increasing their inflammation, their oxidative stress? There's so much that can be learned, but just looking at the lipid profile gives you so many clues initially to say, oh, I need to dig a little deeper here. I need to dig a little deeper there. And I mean, the lipid panel is one of my favorite things to look at in terms of trying to help me understand what's going on with the individual.
Man, I'm chomping at the bit. I got to get it. You're killing me. This is so good. So this is going to be the hard part about doing this course, because you and I are going to want to wax for 90 minutes all the way around on stuff. We're getting to questions going to be nutty, because I think about LDL and HDL, and the first place I go immunologically is, what are they there for? Well, one of the main functions, not just reverse cholesterol transport or carrying the cholesterol, to your point, the steroids around the body to drop it off the tissue to build them. But oh, by the way, HDL is one of the primary mechanisms of clearing the bacterial debris in the bloodstream, right? If you get meningococcemia, your HDL will go through the roof, and then it'll disappear to zero when you test somebody's blood at death, because all the HDL is now back in the liver because it took all the LPS away. So there's so much talk about immunologically. There's so many cool things we're going to riff on. Man, I'm so excited to do this in whenever we hit lipids, when it's January or February. It's going to be a blast.
We're excited. And those of you who are listening, we will be taking the presentations and making a one-page summary every week for you. And then what's really cool that I love that you guys are doing is we're going to create specialized panels based on what you guys teach. That's the thing I'm most excited about, is people can then go order the specific lipid panel that you create for this course, right? Beyond the lipid panel they normally order through Request or LabCorp, that actually has all the biomarkers that you would recommend that they consider. So, right, looking at things like ApoB, Lp(a), MPO, oxidative LDL, homocysteine, and omega check. So everything you talk about each week becomes an instant panel that people can just click and order for their client, which is really, really cool. And I think that's how we make this applicable for busy pracs who just need to go back to clinic the next day and go, what do I order? Okay, great. Yep, I remember exactly why they taught me that. I'm going to order that. And now I'm going to start catching this stuff for my clients early, finding the root cause and truly helping them reverse it. And so I think this is going to be a massive change in the way a lot of people do practice. And I'm really excited. I want to, before we move on, I mean, I think we're going to talk about insulin resistance next. And so we can kind of lump these two together. We often think about running a lipid panel on an adult, looking for signs of insulin resistance in adults. And we don't often think to test our kids for these types of things. And Dr. Magryta, I mean, you have a ton of experience in pediatrics. Are you testing kids for insulin resistance? Are you looking at their lipid panel, and why?
Yeah, so here comes 3 ways to skin this cat. So my wife has a slide she shows in lectures where she teaches, and she shows a picture of 3 children up on the screen, and they're in various states of metabolic appearance. And by metabolic appearance, I mean weight. One child significantly overweight, one seems to be normal weight, and one seems to be underweight. And she asked the question to the crowd, what is the metabolic health of these 3 children? And invariably, most people will say the 2 leaner children are healthy and the overweight child is unhealthy. And the answer is completely wrong. They're all unhealthy because the inputs are identical in the 3 kids. And so I think this is another plug for lab testing, right? So when you say, and I'm going to dial it back actually a little bit, it's actually a plug for a good history first to give you that answer. Because when I ask a child who looks to me to be on the continuum of a normal body habitus, i.e. the BMI or waist circumference ratio, or whatever we're using this day and age, my eyeballs, frankly, most of the time is fine. And I say, well, what would you eat for breakfast? And they tell me, what'd you eat for lunch yesterday? I go, your risk. And so that's my red flag for what's happening. And then of course there's social determinants of health. If this child is coming from a very distressed home, where there's a lot of trauma going on and things, and that's a child I'm going to be a little more acutely aware, trying to look at, because usually there it's associated with more eating dysregulation, let's just say, so eating to feel comfort. And so there's a lot of places I'm going to start looking. So in the world of pediatrics, again, the continuum of ASCVD and insulin starts at birth, right? So if you're being exposed to high levels of sugar in utero and high levels of sugar post utero, you're going to have higher risk of insulin resistance at an earlier age. So there really isn't a time course of when. I'll tell you this, if I'm drawing labs for any reason, venous wise, that is, I'm drawing a lot of these labs just as screening. And I'm going to sit there and go, I'm going in for this. Can we draw a lipid and a uric acid in this as well? And invariably, if a parent says yes, I'm all in. If they say no, I say, well, here's the reason why, but I'm okay with that next time, maybe. But it's sort of a snapshot of my fear is that actually most of these kids are at risk. So I don't really ever say to the parent, nah, he's not in it. We'll do that someday down the road. But often the biggest impediment to getting this done is getting the blood drawn, because a lot of parents are averse to drawing blood on their kids unless there's a really big reason. It'd be super nice to get a lot of this stuff point of care testing from a finger stick, because then we could do a ton of stuff. But as of right now, that doesn't appear to be the case. But yeah, so that's how we sort of see that, Kate.
I love that. I mean, so you have some stuff in your metabolic panel that you're going to be covering in week 4 of your course, where you guys talk about alkaline phosphatase, uric acid, leptin, things that, most docs who are listening might think, well, I could start to run insulin more, or check A1C more maybe. But there's things that you're talking about beyond that. Why are you looking at those types of biomarkers when you're thinking about metabolic health?
So there's actually a thought that came to me at the end of our last little discussion that I think maybe helps lead us into this discussion. And that is, the more we understand about what is actually happening from a root cause level, the more targeted our treatment intervention can be with the patient, right? If all we look at is a total cholesterol, we don't look at anything else. Okay, it's high. Okay, why, right? In terms of, do I just give them a statin? That's the only thing I have to choose from, or I give them red yeast rice from a nutritional supplement standpoint. If I start to understand what else is going on and contributing to that elevated cholesterol, then my treatment can be more targeted to getting to the root cause and starting to shift metabolism with the individual. So looking at their leptin levels, looking at uric acid, looking at GGT, myeloperoxidase, some of these other markers that show us maybe dysfunction in the liver, right? Are they, particularly like GGT, uric acid, those are metabolic markers that tell us that things are off. There's an imbalance. Either there's been exposure to environmental toxins and the body's struggling. This was something that I didn't learn in medical school, but an increased level of GGT is associated with an increased risk for diabetes. And more often than not, GGT is going to be elevated because of exposure to environmental toxins. And we always think about it from an alcohol standpoint or maybe a Tylenol standpoint, but there are plenty of pesticides and herbicides, heavy metals that can impact the liver in a negative way, and the GGT starts to rise. And it's an early indication that there's a body burden of toxicity. Again, if all I'm doing is going after the cholesterol or the high blood sugar, and I miss that makes it really, really hard. And same with uric acid. That just means that there's a toxicity level in the body that we're missing that's contributing to the overall inflammation of the body, oxidative stress. And where we see this manifesting itself in a disease process is in cardiovascular disease. We see the plaque burden associated with that. But the root cause of the plaque burden, as Mark Houston always says, is threefold, right? It's oxidative stress, inflammation, and immune dysfunction. So how can I get information about those three things if I'm only looking at cholesterol? I can't. We have to look at some of these other markers.
And to dovetail on that, we've known about the connection between toxins, diabetes, and GGT for over 20 years. Ducky Lee was one of the first seminal papers to look at that from Agent Orange use in Vietnam. I mean, this is not new stuff. The fact of the matter is, it just doesn't permeate the typical lexicon of medical education, which is a sad reality. But this is what this course is going to really do, is you are going to really start looking deep into the stuff that gives us the why. Because I think if we just start throwing out here's the test, here's what you need to know, and don't give the backstory of the why like you just did, people aren't going to walk away feeling like they're empowered to know this is a real truism. And I think the other thing people are going to gain from this is we're going to give them real articles and real discussions to stretch their mind. Like I just pulled up an article today that I thought was fantastic called Fructose Reprograms Glutamine-Dependent Oxidative Metabolism to Support LPS-Induced Inflammation. Holy cow, what a mouthful, right? But this is in Nature Communications a couple of years ago. But what that's really saying is, to your point, uric acid is driving inflammation dysregulation. But you and I were taught in med school, uric acid is driven by protein degradation. So meat consumption. No, the number one cause of uric acid now is fructose. Well, what is fructose actually doing? Well, fructose is actually changing immune polarity to be hyper-inflamed. And so these are things that we can start saying to somebody, you're riffing on here, LDL check, but oh, by the way, you have a uric acid that's elevated. You now know two things are linked. Is it possible this is a fructose problem? Or is it a glucose polymer problem making fructose via the polyol pathway? There's so much cool shit we're going to riff on here to really help people understand where this all starts. But there's a story that I think you're going to be telling everybody that helps them, because I think story is really a great way to understand. And so instead of being some dry discussion around a lab biomarker that just is X, this is going to be really a story education, which that's why I'm excited to do.
Yeah. And I think it's interesting because, we remember you would get like these blood panels from your Access or your LabCorp, your Quest rep. And you could sometimes create custom panels with that. Or if you're ordering things enough, you could check things off and you would kind of remember what biomarkers to check off. With this new model, we're democratizing the ability for folks to create a very customized or broader set of panels that they run. So it used to be the metabolic panel was just screening for metabolic dysfunction. It might not tell you a lot about the root cause. But I love the way you guys have started to add some biomarkers alongside the labs docs are used to running to say, hey, you know what? You should check out a toxicity potential root cause for dysfunction here. Hey, you should check out a potential inflammatory or immune component of dysfunction that you'll find on a regular panel. It's just adding those few extra things can really tell you where to look, which I think is really interesting. So I love that along with like the liver enzymes, for example, you also have GGT, uric acid, all the metabolic assessments. It's so cool. And I think it's really, like I said, going to change practices. So it's interesting because we talked a lot about liver health just now and environmental insults. Dr. Lundquist, you have an interesting take on blood urea nitrogen, creatinine ratios, AST, ALT. I mean, you both do. Do you want to shed some insight on that before we move on to talk about nutrients?
Yeah, so I think I'm gonna back up just a little more again, and there's two things I want to share that I think will be helpful. One is that as physicians, I think we've been kind of trained and brainwashed into this framework of if you don't identify the abnormal lab and have a answer for why that's abnormal, then you're embarrassed in front of your peers, right? I mean, I remember in we going rounds in the hospital, you were constantly trying to look things up because you're afraid that your patient was going to have something that was, the creatinine was a little high, and now you're going to be asked why that is, and you maybe don't know, and so there's this. We were placed in this fear state. And a lot of times I remember as a resident and even as an early staff physician, like I kind of didn't want to order certain things because I didn't want to know if they were wrong because I didn't know what to do with the answer. Like, okay, great. So their GGT is 70. What does that mean? I don't know, right? And that there's this fear that has come, I think, with part of our training, our mindset that if we don't know what to do with the result, it's like I had a physician who used to say, look, don't stick your finger up your nose if you don't like the result, right? And so if you don't know what to do with it after, don't do that, right? Well, it's kind of the same thing. Like, I don't want to order a lab that I don't know what to do with the result, particularly if it's abnormal. And so I think one of the things that we're going to try and help anybody who signs up and participates in this is to just feel more comfortable in knowing what to do with the result, how to interpret it. It's okay if, And then also not, so this is the second part of this, is that we're not just looking at whether it's normal or abnormal, right? Back to Dr. Chris's binary approach to things, right? It's normal or it's abnormal, right? But everything is a continuum. Everything has a spectrum. So what is the optimal level of where that lab should be versus where it is currently? That gets into the point about ratios, right? So when you start looking at ratios, it helps you get a better sense of where the optimal state of the individual is at. So when we look at an AST to ALT ratio, or we look at creatinine to BUN ratio, that gives us information about what's going on, and we have these optimizations. But again, even within a ratio, you have to then dig back and say, okay, well, this ratio looks great, but wow, the BUN is extremely high and the creatinine is really high. So that ratio looks good, but it's not where we want either of those levels to be originally. And so those are the things that we're going to kind of tease out. And our hope is that anybody who participates in this boot camp and workshop is going to walk away not only feeling way more comfortable in getting just the basic labs, CBC, chemistry panel, lipid panel, but they will have confidence to be able to go back, and excitement. No more fear. Like, we want to get rid of the fear, right? We want excitement about, this is why I'm ordering labs, because when I get these results, I know what to do. At least I know what they mean. I still may need to learn more about what to do, but at least I know that, yes, this is a problem. We can do something about it. Does that make sense?
Yeah. And let me dovetail on that again, because this is the thing I teach med students all the time, right? So when you ask a med student what an ANA is, right, or what an ALT is, they'll give you the textbook answer: ALT, alanine aminotransferase. Well, what does it do? Well, it just tells you if the liver's injured. No, what does alanine aminotransferase do? And they don't know. And so part of this is we're going to teach, what does it do? And at alanine aminotransferase, it's an aminotransferase, right? It's transferring an amino group. It's involved in switching between amino acids. And right, so you're actually moving one group to another, depending on if it's the AST that's being functional right now or the ALT. But what's super fascinating is it's telling you that the enzyme's upregulated, which means you're needing more amino acids to be shifted for production, which means something's being damaged to be replaced. And so what the ALT is actually telling us is that the liver's under assault. And so then it goes back to, hey, why is the liver being assaulted? And then the question, to your point, as you're making it, is, well, we need to start now digging into the other labs to say, why is the liver being assaulted? Is the GGT up? Well, we know now it's a toxin assault. Is the uric acid up? Well, now it's a fructose assault, right? So we're now having an understanding, but now we understand what ALA is, right? Instead of just, it's just a biomarker, ALT, right? ANA, antinuclear antibody. What does it mean? I don't know. It's just a marker of autoimmunity. No, what does it really mean? And the students finally get it when I teach them. It means the cell's being broken. The nucleus is open. So now nuclear protein has been shown to the immune system. This is the key that I didn't learn in medical school, that functional medicine has taught me how to think of this in terms of why, not just is, but why. And I think that's the key.
I feel like all of our favorite class, maybe not in the moment, but now looking back, was probably biochem. Like, am I wrong? Because you look back and you're like, oh my God, it's everything. It's everything. When you learn how the body works and how reactions work, how chemical reactions work to help you build tissue, break down tissue, do every single metabolic process in your body, it's like you have the key. And the brilliant part is we have the things to measure that in the blood through a regular blood draw. It's truly phenomenal what you can learn when you look and when you understand what you're seeing on a deeper level. So yeah, super pumped for this whole course. You guys have a really cool set of biomarkers that you're talking about at the end of this course. So with your blood cell and antibodies panel that you're going to talk about, you also included things like a full iron panel, right? So not just looking at the red blood cells, but you're looking at a full iron panel, not just ferritin. And you're also looking at things like B12 and methylmalonic acid. Why did you guys decide to include those biomarkers when we're talking about looking at the health of red blood cells?
So I think fundamentally, again, if you go back and look at med school education, anemia, if we're going to just riff on anemia a little bit, anemia was this issue of, you might have low iron, right? And then that would come into one class of anemia, or you could have a high B12 or a low B12 or low B9, and that's another class. But what's super fascinating to me, and I learned this sort of in a backwards way, started testing B9 and B12 levels in autistic children, and they were super physiologic. They were through the roof. And I was like, that's interesting. First one, second one, third one, 10th one, they're all high. And so what it was telling me is that, okay, for some reason, there's a whole lot of B vitamins floating around in these children, but they're must not be doing something because there's a lot of dysfunction, dysregulation occurring neurologically and in these other ways. And so functional medicine says, well, let's look at the metabolites that are around the enzymatic reactions that are involved in this. And oh, by the way, methylmalonic acid is one of those metabolites. And so if methylmalonic acid is abnormal, then you could say, okay, now I get it. Now the B12 is actually non-functional, as opposed to the other way. So it comes back to the discussion around function. And so the biomarker in this case is sort of looking at the whole enzymatic reaction to make sure we're not missing the story. Because in this case, if I said the B12 is super high, 20,000, and their anemia was off, and I'm like, well, that doesn't make sense. Well, it does once you see the other pieces of the pie.
Yeah, and I think it becomes more of a common sense thing, right? You stop looking at this as, again, going back to, I love the example at the beginning, binary. It either is or is not, right? I mean, the example that comes to mind is, if you're floating things down a river and somebody dams up the river, and now all of a sudden you have more of these floating things because they're not really moving down, and so you think, oh, well, I guess I don't have to put any more floating things in because there's plenty in the water, but nothing's getting where it needs to go. There's no thought process of, well, that's weird. There shouldn't be a bunch of floating things right now because I keep putting them in the water. They should be going downstream, but it's not. But it's normal. Your level is normal, so we don't need to add anything else. You ask the question, wait, why is their B12 or their B9? They're not taking supplementation. Why is it so high, right? Because there's something damming up the process, right? There is something that is not allowing those vitamins to be utilized in a normal way, which our B vitamins are extremely important in detoxification pathways and neurotransmitter pathways. And so these individuals get these high toxin levels. They don't produce neurotransmitters in the same way. And anybody who has that happen to them is going to not function normally from a neurological standpoint. And then we know from an iron standpoint that it has more functions than just hemoglobin, right? It is involved in all of the detoxification processes. It's an acute phase reaction when you look at ferritin, which is a component. It's a storage form, and there's a lot that we can learn from just looking at the iron levels about, again, what is the state of health from an immunological standpoint, from a detoxification standpoint, and from an oxygen carrying standpoint. Myoglobin also has iron in it and is part of the muscle and is really important from the standpoint of muscle function and being able to exercise and do those things. So there's a lot that we learn from those nutrients. And the other one I'm just going to throw in there is iodine, right? And we're going to talk about thyroid labs. And there's a lot of controversy about iodine. And I never checked iodine before I actually started learning about the purpose of iodine in thyroid function, and had no idea the important role that iodine not only plays in thyroid function, but all glandular function and even in the body. And it's an integral part of thyroid hormone, which is why we call it T4, because there's 4 iodine molecules, right? So we're talking about these things from a functional level, not just is it normal, is it not? We're looking at it, and you'll learn all about these things so that when we walk away from looking at a test, you'll have a better sense of what's going on with that individual. And I will say this over and over again in these workshops that we do. Ultimately, the labs are there to guide us, right? It's not a binary on-off type of a thing. They're there to guide us, but who are we actually treating? Not the labs. We're treating the person in front of us. And we have to take what they are telling us from a symptom standpoint, from a history standpoint. We look at do their physical exam and see what it tells us. We combine that with the labs and all of that data. And now we have the ability to even have more biomarkers with the wearables. We look at that data, and then we can be more capable of personalizing a treatment that is going to get them healthier and optimal state of well-being, which is so exciting. It's never been a more exciting time to be a physician and to care for people, because we have so many tools and so many ways of understanding what's going on with the human body.
I think this is a super good time to make a distinction between adult medicine and pediatric medicine, because although you understand adult and pediatric implicitly, and I understand it both, I spend most of my time in the pediatric world. And when we look at these markers, most of the time, in general, especially nutrient markers, people don't understand the level of dysfunction their child is suffering because they believe their child is doing well. And I'm going to give you the sort of corollaries to the why. We live in this world of triage theory of medicine, right? In the triage theory of medicine, if your vitamin D level is 20, you're fine. You're not going to get rickets. So you're good. But that says nothing about what else does vitamin D do. Is vitamin D involved in anything else when it's in the 30, 40 range? And now we know very clearly it's over 90 hormones 90 proteins that are made inside the nucleus that are involved in different functions that are highly immune related, especially. But I took care of a kid one time that really hammered this home for me. He was a cystic fibrosis patient. And he had CF his whole life. And he had really bad lung disease. And he ended up having Burkholderia-cepacia. He had significant problems to the point that he ended up getting a double lung transplant when he was in his early teens. Like I think he was 13 when I was at UVA. And this kid was just a beautiful kid. And I loved taking care of him. I happened to be in the PICU the time when he was getting this transplant. And he went through it. He sailed through it. And when he got out, he went on a hike. And he hiked to the top of this local hill, which he called a mountain. And he said it was the most amazing feeling to know what it was like to breathe and feel like he could get air in. For him, his norm was dysfunction. And I think so many children and so many adults believe that they're fine because all they know is their level of good, their level of optimal, their level of triage theory of medicine. And so many people are not even close to what their physiologic best is. And that was so poignant for me to listen to this child going, yeah, he just totally got caught. Like he knew his norm. And I think when we go through this course, it's helping everyone understand, no, you do not need to live in this world where you believe this is okay. It's not. You can feel better and you should feel better. And let's chase down the leads as to the why.
Oh my gosh, I'm so pumped up. I mean, this happens every time I talk to the two of you. But this is so great. And it's why I'm so glad you're teaching. No one who is listening will be shocked to hear that we already have a 201 planned out after this course, and that there's tons of resources. You're teaching people how to reflex to different biomarkers depending on what they find with some of these more like 101 basic level panels you're going to talk about first, which really are anything but basic. I think we need a different word for it because it's foundational, but there's so much there. I mean, we didn't even get to talk about zinc, copper, magnesium, omega-6, arachidonic acid, a lot of the immune biomarkers that you guys have. So I think there's a ton that we could talk about. Obviously, we're going to take more than 6 hours in the course to talk about these foundational labs. But I just want to take the next 30 seconds to ask you guys what you want to leave our audience with. So a practitioner who's listening, they're on the fence, they're busy, they don't know if they have time for another course. They're thinking, I know I always wish that I had a little more information about what to do when I get my labs back from my clients, but speak to that person right now to tell them what you can do for them in this course.
I think the reason to take this course is that at the end of it, you're going to feel so rewarded that your time was well spent, regardless of the state you find yourself in now. I think fundamentally, when you have an awareness around your own ability to help your patient beyond the state that you're in this day, this is the reason. You can read 100 articles, and that'll take you 10 times longer than it is to listen to 6 hours of conversation around the combined 25 years for me and Erik's time treating patients that we can condense into 6 hours so that you can walk away feeling like you learned a ton and with references to go back to that is actually in your favor in the long run. If you are overworked and overtired, this is actually a way to synthesize, simplify, and feel the ground underneath you get more solid instead of the shifting nature of not having this information. I know when I first did certain courses of this type, it was daunting in the beginning, but then once you get into it and once you spend the time, you feel so much more grounded. I mean, I can read immunological articles now because of doing some coursework in immunology. In the old days, if I saw cytokine word CXCL9, I wanted to vomit because I had no idea what the heck CLCL. So this is just another way of thinking about that reality. So we're going to get words to you that you feel so comfortable with that you can walk away going, this was totally worth my time.
Yeah, I totally agree. I think one of the biggest values you'll get out of this course is you're going to get a very condensed look at how to interpret labs, right? It's when you go to an integrative medicine or a functional medicine workshop, you may get one section of that will be on labs. So you're getting a little piece here, a little piece there. This is going to be all combined into one. So it's going to be a very efficient way for you to get on top of how to understand how to utilize these tools in a way that is going to change your practice. There was nothing more exciting for me than starting to understand the whys behind the labs, right? I just remember as a resident, like, well, I have to order these labs because this is what the standard of care says. I got to check their A1C. I got to check to make sure they don't have anemia. But I was always doing it to rule out something, not to find out what was going on with the individual. It all of a sudden changed my satisfaction as a physician. There's so much burnout right now in the medical field because we've been stuck in this binary approach. If then this, right? It's like, it's not this is what's happening. Let's change it. So this is going to be a great course for you to get some real tools that you can get your hands dirty with your patients that will really make a difference, not just in their lives, but in how you feel about being a physician again. And that's really powerful. That's really powerful.
I personally cannot wait to sit with each of you for 6 weeks straight, because one of the beautiful things is that after you're done presenting, our students get to ask you questions. And you two are the people that I go to. So I either sit in your lectures or I'm blessed to have your emails where I can actually ask you questions because you're both on the leading edge. You're doing things that are so advanced that I'm just thrilled to put you in front of our audience so that even the most expert person in the audience can still feel like they're getting a ton out of this by being able to ask you questions, because that's also where the rubber meets the road, right? We've all sat in lectures that blow our mind, but you go do it and then you have questions. And people can come back week after week as they go and apply this for a week in their practice and the questions come up. They can ask you and you can help them through it. So I cannot thank you enough for your time here today, your time developing this course, the time you will spend with our practitioners. Thank you so much for the change you're making in the world.
Yeah, you're welcome. It's an honor.
Appreciate it, Dr. Kate. Yeah, absolute honor.